ENCELTO, and Celto Revokinogene Teveretzel Lui, an FDA-approved treatment that may be right for your patients. Visit incelto.com/ECP to learn more.
Hi, everyone. Welcome to the new Retina Radio Journal Club with VBS. My name is Alexis Warren from the University of Chicago, and I'm joined today by Jesse Sengillo from the University of Miami
Hi, everybody. Thanks for having me tonight.
and Sruthi Arepalli from Emory University.
Hey, everyone. Glad to be here.
Today, we'll be discussing a paper called Association Between Antibiotic Prophylaxis and Endophthalmitis Following Intravitreal Injection, a Systematic Review and Meta-Analysis, written by Liu et al. And published in Retina in September of 2025. I'll start by throwing it to you, Dr. Arepalli, to summarize the paper.
Yeah, absolutely. Happy to. So this was a systemic review and meta-analysis that compared endophthalmitis incidence following intravitreal injections with or without antibiotic prophylaxis. The way this review was done is that it searched databases including PubMed, Embase, and Cochrane Review from inception to August 2024. The articles were included if they met the following criteria. If they examined the incidence, prevalence, or risk of post-injection endophthalmitis that was associated with prophylactic topical antibiotics administered before or after intravitreal injections, and as long as these were observational studies, such as randomized controlled studies or non-randomized studies. The primary outcomes measured were endophthalmitis rates after an intravitreal injection, with secondary outcomes including things like the distribution and quantity of microorganisms and best corrected visual acuity. The study quality was assessed with something called the Newcastle-Ottawa scale. And for those of us who are not familiar with this is a metric to see how representative these cases are and how generalizable they are. All the studies that were included were deemed to be of high quality. And one of the rationales for the study is that while povidone iodine has been shown to reduce endophthalmitis risk, the use of antibiotic prophylaxis, which has been shown to decrease the bacterial load, is still debated. So overall, this review yielded 18 studies. 10 of these studies used post-intravitreal antibiotic prophylaxis regimens, while the other 8 used some mixture. If we looked at the types of antibiotics used, fluoroquinolones were the most common. Overall, in total, these 18 studies showed that there was no significant difference in endophthalmitis incidence between the groups that used antibiotics as prophylaxis and those that did not. This encompassed over 3.1 million intravitreal injections, and it showed a total of 1,426 cases of endophthalmitis. Specifically, if we break this down, you can see that 950 of the endophthalmitis cases were reported out of almost 600,000 injections with antibiotic prophylaxis, compared to about 476 cases in a little over 2.5 million cases that had no prophylaxis. When you look at the analysis, the authors found that there was no significant difference in things like microbial analysis in the culture positive rates that were found in 11 studies. If there was cultures taken that showed organisms, they showed that overwhelmingly, the majority of isolates were gram-positive bacteria, with coagulase-negative staph being the most common. In terms of visual acuity, antibiotic prophylaxis showed a decrease of 4-point letters compared to the non-prophylaxis group, but this was not statistically significant. Overall, the study concluded that topical antibiotics did not reduce the risk of endophthalmitis or improve visual acuity outcomes post-injection, and given the potential risks such as fluctuations in conjunctival bacterial loads and potential resistance, they do not recommend routine prophylaxis.
Thanks for that awesome summary. I'll kick it to you, Dr. Sengillo, for your quick reaction to the paper. What were your thoughts? Were you surprised by the lack of difference in endophthalmitis rates? And how does this compare to, your current injection protocol?
Sure. Overall, not too surprised. We have the protocol that we use at Bascom does not include prophylactic antibiotics, and a lot of that protocol was developed surrounding conversations of discussions about some of the publications that were included in this meta-analysis. So Overall, I wasn't too surprised that there was no difference since there's already been kind of a good review of the literature in the past via our department in deciding these protocols and having some sort of awareness of those. What I do find interesting is always especially with retina, is that we can never really count on a future clinical trial or really robust prospective study for some of these questions that seem really basic, because endophthalmitis is so rare, and there's of course ethical concerns for the ways that we would design clinical trials and ways to study these questions. But overall, I really liked the paper. I thought the meta-analysis was a really great way to kind of organize the literature, summarize a lot of the different findings, and ultimately give a best attempt at trying to apply some statistics to some of these studies as a group. Overall, I think in terms of our practice here at Bascom, we don't use antibiotics, but I think although they are relatively a low risk adjunct, I think there's enough evidence to suggest that there's really no added benefit, that it's not worth adding to our protocol. But do definitely understand the differing opinions out there.
Yeah, I would agree. I would say, at my institution as well, most people don't use the prophylactic antibiotics. But I will say that some of our more senior faculty do, and part of that I think is because we had some of this great data, we weren't sure, and it seemed like the risk were so low and benefits could be so high. And historically, it's hard, I think, for us as physicians sometimes to change our routine. So for them, I think that the risk benefit makes sense to just add in, whether it's just a drop, and for patients too, for those who've had injections for many years and started out with this kind of prophylaxis, I think it's hard for them to kind of change their mind and all of a sudden realize that this might not make sense or be based in evidence. So easier just to put it in a drop and send them on their merry way. Dr. Arepalli, any thoughts?
Yeah, I tend to agree with both of you. I think povidone iodine, we've shown really cleans out the flora and also reduces endophthalmitis risk. So I've never found the need to supplement with topical antibiotics. I think a situation I run into, and we can talk about more in the next discussion, is what you do when patients can't tolerate povidone iodine. And so what kind of topical antibiotic regimen you use, or do you not do anything, or what are standard practices there. But in a run-of-the-mill patient, I usually will just do iodine and call it a day.
Well, that'll send us right into our break. I'll remind the audience that we'll have a more in-depth discussion on the other side.
Support for this podcast is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. Have you heard the latest news from Vabysmo? There's even more to see with 4 years of long-term data. Explore the RHONE-X open-label extension data at vabysmo-hcp.com. That's vabysmo-hcp.com. Start first with Vabysmo.
Welcome back to the new Retina Radio Journal Club with VBS. Now let's get into a longer discussion about the paper Dr. Arepalli summarized in the first part of this episode. I really liked that point that you brought up about some of the other prophylactic measures that we do to try to decrease our infection rate, like iodine around the eye. And for some patients, we know this can be really intolerable, or they have a quote unquote allergy to these things. And so thinking about those types of patients and how we're avoiding injections, what is something that you do, or what are some of the tips that you have for these kinds of sticky situations?
Yeah, I think I have such a small number of patients who say they have an allergy that I don't know that I have an official protocol, but I can talk about a couple of different things that I've tried in the past. So I know there's been some great literature, especially coming out of Wales, that's looked at chlorhexidine as a prophylaxis agent that tends to be gentler on the eye, and I think people have less side effects. I think in some patients, I've educated them that it's probably not an allergy, but an irritation. And so I will try to do, as little betadine as possible, and then rinse out the eye as well as possible afterwards and see how that goes as well. And then there's the rare patient who insists that they can't tolerate the betadine. And we don't have access to chlorhexidine very easily at Emory. And so the other thing that you can do is a round of some type of antibiotic. So when I was a fellow, Dan Martin would tell me about a patient that he treated, and he would always do 3 rounds, I think, of gentamicin 5 minutes apart. And he said that he'd never experienced a case of endophthalmitis. This patient got injections for a long time. And so that's always been in my back pocket as well as a type of antibiotic prophylaxis for those patients too.
Yeah, I think that those are all really great options for me. In my clinic, most of the time, I do talk to patients at length, kind of about more of an irritation versus an allergy. And I would say about 95% of patients I can convince to still use it, maybe perhaps more judiciously, and making sure to wash it out. But I feel most comfortable doing that. I have on the rare occasion used just topical drops for those that really insist, but that does make me a little bit leery, and I feel more confident with the iodine. How about yourself, Dr. Sengillo?
Yeah, pretty similar to both of you. I agree that usually when people describe some kind of intolerance to betadine, it's more an irritation and less a true allergy. So, like you said, I'm able to convince the vast majority to kind of give it another try and educate them on lubricating well, the day before and the day of, and then also after the injection, which tends to kind of help those symptoms. And then the very rare event that someone has either a true allergy or really would almost rather not have an injection than have betadine, I'll resort to things like chlorhexidine or like kind of a variant protocol, but it's incredibly rare for that. Even with patients that have had systemic allergy to iodine, like contrast agents, I feel do extremely well with topical betadine. So
I think too, over time, I've also become more comfortable with using less betadine, and patients have less irritation. So that's just a really small tip. The less you use, the less they'll complain, and it will make the appointment go a bit more seamingly. Um, what do you guys think about this paper and how it addressed some of those prophylactic measures like the iodine we talked about, and how those might confound the effects of antibiotic prophylaxis, or how they were even used or approached in these studies that were looked at?
Yeah, I'm really glad you brought that up because I think it's not totally clear in this review what the delineation is. So, after this paper, I was left wondering if antibiotic prophylaxis, either before, during, or after, was used in conjunction with iodine or if it was just a singular process. I reviewed some of the papers that were referenced here, and it seemed like sort of a mix. There were some papers that detailed exactly what they did. They have an iodine prophylaxis or aseptic technique they used, and then the antibiotics they used afterwards. And others were less clear. And I think that does matter because we see that there's not a significant difference in the two groups of the antibiotic prophylaxis and endophthalmitis rates. And it makes you wonder, is it the iodine that's doing that? And then the antibiotics are just extra icing on top? Or is it that we're comparing apples and oranges? Some people are getting 2 of them together, and some people are just getting the one. So I think it matters, and I think that part is a little bit unclear.
I would totally agree. I would say that's a big confounding part of this study for me, because maybe I'm such a believer in that prophylactic measure. To me, not having that address or not having those specifics could really change the way that we look at this data. Dr. Sangillo, your thoughts?
yeah, completely agree. Not to piggyback exactly on what you guys said again, but for this piece, I agree. It's hard to parse out and make these studies perfectly controlled, especially for a meta-analysis of many
Right.
studies that were retrospective. So we may never know, but I think this study did a good job in doing some kind of comparison to give us a little bit of some kind of evidence basis for what we do.
What did you guys think about the culture positive as the marker for endophthalmitis in these cases? I think when we think about endophthalmitis, sometimes it can be more of a clinical diagnosis, right? So if we are putting our hats on just looking for something that's culture positivity, are we missing a group of people? We know this is rare, but something I was thinking about, when I was reading this.
Yeah, culture positivity, sometimes we can only get up to 50%, right, for endophthalmitis cases. And so I totally agree. I don't know that that's the true marker. I think it's interesting to look at to see what ends up growing if you do grow something. And I did wonder to myself how much of that was contaminant versus other things. But again,
Right.
big meta analyses, it's hard to know exactly, but it's a nice fact to know.
Well, thank you both for some good discussion on a very interesting paper. And thanks to the audience for listening to new Retina Radio Journal Club with PBS. And stay tuned for further episodes.